All right, Jer Bear, good morning. Happy Monday.
Christopher.
All right, so we're going to go over a quick postpartum hemorrhage call. So this was coming out of a community hospital OB department that is roughly about 9 minutes from a tertiary care facility that we work with. It was coming out of their OB going to this University Medical Center's operating room for a 38-year-old female patient with a diagnosis of postpartum hemorrhage, status post a normal vaginal delivery. And all they told us was the patient's on a non-rebreather, had multiple points of IV access with blood, lactated ringers, and Pitocin running. So the crew did a great job of recognizing they needed a hustle. They were on scene in less than 8 minutes from the time that they went out. They got up on the floor in another 3 minutes. And what they found was, on their arrival, a 78-kilogram female who is 38 years old, who just delivered a 39 weeks gestational age healthy baby boy about less than 90 minutes ago. They did notice the birth itself was uncomplicated. Afterwards, they did notice some hemorrhaging starting. So the outside hospital initiated basically ACOG stage 1 blood loss protocol, where they continued the oxytocin. They gave Hemabate, and I believe misoprostol was in there as well. And the hemorrhage did not subside. So upon our crew's arrival, they noticed the female was on a non-rebreather. She had 2 points of peripheral IV access, an 18 gauge in the hand and a 20 in the AC. She was getting lactated ringers and 1 unit of packed red blood cells. The obstetrician at the sending facility is estimated that the blood loss was around 2 liters and growing. There was a nurse who was standing on top of the patient, essentially trying to stimulate uterine contraction through fundal massage. They had given all the hypotonics, right?
So
Uterotonics, and had called us to transport this patient to a tertiary operating room.
is she alert at this point?
She was alert. She was
Okay.
pale, cool, and a little bit diaphoretic, but she was talking. She had a non-rebreather on. She answered our crew's questions appropriately.
Okay. You didn't get the vials yet, right?
Yeah. So our crew just immediately put them on our Zolox series, which gave them vital signs of a blood pressure of 72/38. Heart rate was 138. Respiratory rate was 24. She was satting 98% with an end tidal of 24.
Does that correlate with the blood pressures they were getting at the hospital, or we don't know?
They were saying the manuals were giving them 60/30s.
So pretty close. Okay. But she's still alert, talking.
She is still alert. She is still talking.
Okay.
The crew wrote in their narrative that there was copious amounts of blood-soaked linen and multiple sponges, lap sponges, and chucks that were blood-soaked standing around the room and on the floor.
So they're estimating 2 liters.
And growing. So the crew noted that there was blood coming out of the patient when they walked into the room.
And it's not slowing down.
No.
Okay.
So we're 90 minutes post-delivery. Prior to our crew's arrival, she got 2 liters of lactated ringers. She had 1 unit of blood, packed red blood cells hanging to gravity. And she got the uterotonics. I think she got misoprostol and Hemabate.
Mm-hmm.
In addition to the Pitocin was still running.
Mm-hmm. So, like, what are you thinking right away?
Right away, my first thing would be get a blood pressure that is reasonably close to a map of 60 or greater and get out the door with as much blood as I can. Because obviously they're calling us to all the interventions they've had have not been successful. This facility did not have the surgical capability to fix what they need. What the OB at the outside hospital said is she wasn't entirely sure that all of the blood bleeding was originating from the uterus, that there may be something torn in there, but who knows?
Well, yeah, probably difficult to see with that much blood coming out. So if she lost 2 liters of blood, how much blood would you be comfortable being like, we got to go 10 minutes, right? That's what you said?
10 minutes, roughly.
Yeah. How many units do you need before like, we're just going to go?
I would run with 4 and 4, or 2 and 2. So I'd want to walk out the door infusing 2 units of red cells and 2 units of fresh frozen plasma. That would get that on. Given with our rapid infuser, we would be rolling into the operating room given the last one.
That's probably reasonable. So what actually happened?
So what the crews ended up doing, they actually did a great job. Their scene time was only 22 minutes. They placed 2 additional PIVs, a 16 gauge and an 18 gauge. Well, one of the crew members, they did not have any more blood at that point in time. They opened the other unit to gravity, took it off the pump that they had, and they used our 410 medical life flow and rapidly infused a liter of LR while they were getting more blood up there. Our crew also, while they were doing this, I believe one of the medics was starting the additional PIV, one of them was rapid infusing the LR, and our nurse was mixing the TXA. So they gave per our protocol, they gave 1 gram of TXA over 10 minutes, and then they started the maintenance dose of another gram in 250 cc's at 31 mLs an hour.
Did that make any difference?
So their next set of vitals was a little better, 78 over 40, heart rate of 124, respirations of 22, sats of 98, and an end tidal of 26.
What about the bleeding?
So the bleeding, they said, was difficult to quantify because the OB attending and a resident were in there trying to, I'm assuming, trying to find a source or to pack it off. They said the bleeding was hard to quantify, but the vital signs improved.
Okay, so they couldn't get any more blood though.
They actually did. So they weren't going to stick around. They were ready to life flow in another liter of LR, and they did reach for the vasopressin to start if they needed to. But the outside hospital was able to bring them up an MTP pack. So they actually left with 2 units of red cells, 2 units of white blood plasma, and 1 unit of platelets. They took it all.
Okay. So I'm going to ask you because I actually don't know. Is it different than like a trauma? Like, do you really want the blood pressure to be up, or you're comfortable with that lower blood pressure, right?
I think what was driving the crews was the low blood pressure with the unabating bleeding coupled with the poor clinical picture of this patient. She was pale, she was diaphoretic, she was conscious and alert, but she was alert to verbal and occasional painful stimuli.
Right, but if you know you got blood coming, right? You given the pit's still going, right?
Yep.
Now you gave TXA. Are you really going to want to start vasopressors?
No.
Probably not, right?
I think their intention with the vasopressin was under the assumption that they could not have gotten blood. They were ready to roll out as fast as they could. And if her blood pressure dropped, they were probably going to... what they had told me was they had mixed the drip, but had pulled 1 unit to give 1 unit IV push, which, given its half-life, probably would have risen the map enough for the 9-minute transport.
Okay, but ultimately, blood over everything else.
Yep. And they got an MTP pack, and they gave the TXA, and they grabbed the MTP pack as they were walking out the door.
Gotcha. And we probably don't know what their lights were in this case because we don't have all the information.
There were no labs. They did not stick around for labs or charting or anything like that.
Can't blame anybody for that.
I would not have either. So en route, I will tell you, her vital signs never really changed much from that 70s over 40s. They endorsed that they had packed her vaginal area as best they could, and that those packings were soaked by the time that they made it to the operating room at the receiving facility. But it was pretty incredible with what they were able. They actually got the entire MTP pack into this patient by the time they got to the operating room.
I guess all you can do, man. If you got the blood, give the blood.
They used 2 410 medical life flow infusers and 1 on each side, and they got both units of reds, both units of whites, and the platelets in as they were walking into the operating room. They said the last unit of plasma, or they did the plasma first, and then the last unit of reds and platelets infused as they were walking into the OR. So the receiving facility, they said, was definitely on the ball. They put her directly on the table. There was no prep, nothing. They walked to the operating room, gave a report to the anesthesiologist, who were, and they were scrubbing her as they were walking out.
Nice.
So I think the whole call, from the time that our crew left until they handed the patient off, was about 49 minutes.
If this patient was, say, You know, sometimes they get delayed bleeding, right? Like they'll go home and they'll come back. Now they're bleeding a ton. Does that probably change this picture a little bit?
I would ask you, would that change whether you would give TXA or not?
It doesn't, but it changes what this patient looks like if they're coming from the ER rather than coming from OB, because they're not going to have all the extra things. They might not even be able to get oxytocin. They might just be having blood and maybe TXA. Right?
Yeah.
Which that could be a scary situation.
Yeah, absolutely.
Because order of precedence, what are they saying? What's the...
For the stages? So the ACOG guidelines, it actually, if you look at the ACOG obstetric hemorrhage checklist, it goes from basically prophylactic, which they keep the oxytocin running for a period of time after birth, to stage 1, which is 500 to a liter of blood loss, which they would give, continue the oxytocin, and then give a uterotonic. So either the methadone, hemabate, or the misoprostol or Cystec, or a combination of those. I believe in this one they got hemabate and or Cystec or Cytotec. Excuse me, hang on. Misoprostol.
And the reason to do that is just to stimulate the uterine contraction, right?
And all of those are uterotonics, so they're all just stimulate. But if the bleeding is the uterus in addition to something else, it might stimulate the uterine contractions. It's not really going to help you if they're bleeding elsewhere.
Like if they had a laceration or whatever, right?
Exactly. So in this case, it was the what ACOG defines. It's 500 to a liter is stage 1, where they would give the uterotonics and reevaluate. If it progresses greater than 1,500 mLs of blood loss or greater than a liter with vital sign changes, they progress to their stage 2 recommendations, which are all of the above. So the uterotonics and tranexamic acid and blood replacement. They recommend, regardless of lab values, 2 units of packed red cells and 2 units of white of fresh frozen plasma.
Is there a stage 3?
There is not in their recommendations.
Okay. So this is the worst case scenario.
Pretty much.
Very well.
So in 49 minutes, I think our crew did absolutely everything they could, and props to the receiving facility or sending for being able to get them as much blood as quickly as they could.
Yeah.
That doesn't happen often.
I think that's all we got for today.